Good day, team. Dr. Deshmukh, Dean, Dr. VMGC, the organizing committee of Hirak Mahotsav, friends, colleagues, respected teachers, and mentors. I'm honored with this kind invitation to share my experience of the robotic surgery, especially, and the future of AI and three-dimensional printing, and where we will be in next couple decades. Thank you. I've been fortunate to practice and teach and research at the University of Chicago, which is the home to close to 100 Nobel laureates, including our Department of Surgery chairman, Dr. Charles Huggin, who won the Nobel Prize in Urology for the prostate cancer research. Just for fellow friends and colleagues, this is the Lake Michigan in United States, which is the biggest reserve of the fresh water. And Illinois is the state where I am residing, and this is our city of Chicago, very close to the lakefront. This is a beautiful campus of University of Chicago. As I mentioned, multiple disciplines, not only the medicine, but economics, research, law, business schools, and all the disciplines within the same campus. And this is our University of Chicago Children's Hospital, which is my Karmabhumi for current era. A beautiful city, Chicago skyline. There is beautiful monuments. Some of our proud Indian colleagues have found some of the prominent landmarks in the city, which has been enjoyed by tourists of more than 1 million every year. It's very beautiful in summer, but as we are in currently winter, this is an extreme right picture where you will see a lot of snow and often the lake is frozen. And it just shows you that just like a human being, it goes through multiple cycles of the nature, which is very coloratory to us. So what is our aim here today? Our aim as a physician and as a surgeon is how we can reduce the morbidity of the patient. Either it could be just simple pain from any condition, or the morbidity of surgery. And if you look at this article, which is published about 6 years ago, it talks very well about last 200 years of surgery, what we have done as a colleagues and peers that to reduce the morbidity. Now, if you take about the surgery, the simple morbidity is of any incision. Okay, any surgery we do, there is an incision, there is an inflammatory mediators, and we have done this to alleviate this problem by laparoscopic surgery, endoscopic surgery, and we've been at the forefront of this. And I'm sure the medical counterpart has done similar, which we may not be aware about it. As we all know, laparoscopy surgery has been very evident. It has been there for last 3 to 4 decades. Many people are expert, and it uses very simple instruments, and the movements are like a chopstick movements. I've been a part of this laparoscopic surgery in my during training in Bombay Hospital in neurology with a pioneer retroperitoneoscopic surgeon, Dr. D.D. Gaur, which is framed here on the left side, which is world-renowned laparoscopic surgeon. It's nothing wrong doing laparoscopic surgery, but I have seen and evidence my colleagues and which is supported with the literature that there is occupational hazard with this using this technique. And what is that is the related to the carpal tunnel syndrome, other joint pains, spondylolysis, and this is very costly because a surgeon to get trained and practice needs a lifelong devotion and dedication. And if that surgeon, because of this occupational hazard, is not contributing to the society, is going to cost a lot. So we need to think about how we can increase the longevity of surgeon's life for betterment of the human society. Along this era, as we are entering into the biointelligence area and into the era of bioinformation, we have harnessed this very well. And what we have done is everywhere. We've been using the digital analog technology, computer analog technology, and the same has been incorporated into the robotic surgical system. And if you see what is this robotic surgical system, is these instruments are mimicking exactly like our hands, which has a freedom of movement of more than 6 degrees, often more than our wrist joint. And Rich Satawa, who is a pioneer in the robotic surgery, his slogan is bites and bites, no blood and guts. And I think that denotes that how we're going to make a progress in this field. So, what is this robotic surgical system? This is the video clip showing the multiple joints of these robotic arms. So, these are the arms mounted on a stand, which is called as a surgical cart. And the movements which we do at the console sitting are reciprocated through these surgical arms. And these arms have the extension of the ports, what we call, and they are placed into the patient's abdomen. And that's what the robotic surgical system is. And the most common surgical system used is the Da Vinci robotic surgical system, which is manufactured in the United States. I got fascinated with this robotic surgical system back in 2005 in the United Kingdom, along with my peer, mentor, friend, and colleague, Professor Patrick Duffy, and then another our adult urology colleague who worked with John Wickham, Dr. Prokadas Gupta. And I got fascinated with this, and we applied the first time in the United Kingdom and maybe a couple of few people in the world for pediatric surgical application, and that got fascinated me to develop this surgical field. So what has been done? So as I said, we were a couple of probably among some of the pioneers in 2005. And since then, the applications of surgical armamentarium in pediatric urology has been increasing. And now, for example, we did pyeloplasty in 2002, 2005, but the latest, myself, along with my colleagues, we have done a bladder reconstruction using the piece of intestine called as augmentation cystoplasty and appendicogocyclostomy. And this is the greatest feat in the armamentarium of pediatric urology. Along with this, we have been exchanging our knowledge and skills with all the friends and colleagues across the world with the robotic surgical workshop. And these are very important attributes to share our knowledge with the peers for betterment of human society. I'm going to share a small video clip here just to showing you the how the infant pyeloplasty is done with a robotic surgical system. Now, if you see right side, this is a uretropelvic junction obstruction where the ureter is narrow in the junction of pelvis and ureter. We remove that narrow uretropelvic junction and join the ureter back to the kidney. Look on the left side here, how these instruments are making a very diligent and delicate and articulate movements. These joints have a 6 degree freedom. As I mentioned, they are articulating, and the magnification is 10 times. And also is three-dimensional. So you get to see exactly similar like open surgery, but with much more fineness and much more magnified. And you can see the benefits and advantage of tissue handling, tissue magnification, and the intricate anastomosis, especially in pediatric patients. This patient is only about 6 weeks old, and we did a infant pyeloplasty with using the robotic surgical system. Now, is this something new, or was this around for a long time? So let's dwell into the history a little bit. If you read about the history books, it is almost more than 1,000 years ago. Automation was around, and this automation was in Alexandra's Pneumatica and Atoma book. And what he thought about is like automated coin impregnated machines and the wind blowing machines. So these automation has been a fascination to humankind back into the Alexandra era. So this is before Christ, 200 BC. So there has been this huge fascination of human being about the automation. Further on to, if you look at the history, then about 1500 years ago, Leonardo da Vinci, who did a multiple sketches, and in fact, this is the picture from the Berlin Museum about the Leonardo da Vinci's the diagram describing the robot, and this robot monk has been created with his design. So I think, there's a fascination of automation because human being always may have thought that how we can be significantly faster and will be more efficient and effective. I think that's what led us to get into this system where we are now. And subsequently, there has been a lot of industrial robots. I think you all know, more people know that the industrial robots are used in the warehouse for collecting the equipments, for stacking the equipments. This is the robotic arms in the manufacture industry where humans may not be able to participate because of the environmental condition or a dangerous condition where the robotic arms do our work with the extension of the arms. These are the underwater robotics, which are held for the navigation of the underwater system and underwater security and safety system. In regards to the human robots have been evolution in only about last 3 decades. And what was that is in around 1980s, there was an automation of the robotic arm for the laparoscopy. And subsequently, we had an automated camera called as ESOP. And the ESOP did the movements of the camera with our at our voice signal and voice control. And then in 2000, the Da Vinci robotic system came into surgical practice for the human use. And this was actually a reciprocation from the satellite system where the robot arms are used to repair the navigation and the repair the default the satellite system. And these same arms have been subsequently modified and been used for the human robots, and now it exists as a Da Vinci robotic surgical system. You can see the benefits of this robotic surgical system here, that in United States the number of robots which has been installed all along has been increasing, and that tells you just a simple example of pyeloplasty, which is a kidney obstruction condition. Before the robot came in, the minimal invasive pyeloplasty has been much less, but once the robot came in, we can see a big breakthrough. So it tells us that there are some benefits of this articulating system, and that's why the number of robotic surgical procedures have gone up in United States. So that's about the robotic surgical system and where we are. I'm going to delve into little of artificial intelligence. Now, first of all, we need to think about that it's not artificial intelligence, it should be augmented intelligence, because human being intelligence is the most supreme and prime in the human kind. And I think it will be very difficult to replace the human intelligence and human, whatever the human prime function or supreme function is. So I think it's better that we use the term augmented intelligence. It's not artificial, because ultimately the human being is creating this intelligence system. Now, there are cores of augmented intelligence. The simple one is called as a machine learning. Now, what does the machine learning means? That you programming the machine with multiple problems, and then you develop the algorithm to have a solution to a problem. So that's a machine learning, which is a continuous mode. The next one is a deep learning, which is a deep neural network, which is much more complex and involves the step ahead of machine learning. When you put together the machine learning and deep learning together, it forms the augmented intelligence, and that's why AI is. I think artificial intelligence is not artificial, it's a human created intelligence, which is augmented by multiple layers, and that's where you are. But remember, all these things need is a continuous learning. It's exactly like a human being, how we say that, you have to be a lifelong learner. It's the same problem. You have to feed the machine continuously, and you do have to challenge the machine with the multiple different examples, different problems, and you have to keep it in the system for continuous learning. Then only the machine can do much better, and then only similar to the human beings. If you don't do your continuous learning and education, you're not going to do better. So, what is this augmented or intelligence or artificial intelligence or AI in healthcare? And where are we going to go with this? Essentially, is going to streamline the medical practice, what we are doing. is going to navigate us to go in a direction of the betterment. And it is going to be much more efficient because we are using the multiple inputs in the system is going to take us through a streamlined, efficient system. Now, if you look at this, I divided this into four things. For example, simple risk assessment and prevention. You can take a big data and put it in the algorithm and do a data analysis, and you can come up with a solution of who are at a high risk of a problem. And you can target the therapy with those patients who are at a high risk and helping you out for the betterment. At the point of care, when the patients are calling you to make an appointment, or they are asking you to put you on a waiting list, or you have to get the multiple documentation clearance, this all can be done with a simple machine learning by telling the machine to learn and do an algorithm system. If you go a step up, you can have this as a precision medicine. And the precision medicine is most next thing coming up in the medical practice, that is the targeted treatment to the patients who are need. For example, antibiotic treatment. All the time we do culture, sensitivity, and prescribe the antibiotics, but it's not that enough. We need to know what is the resistance, what is the immunity, what is the immunological factor, and the the molecular level bioavailability, and these all can be done with the precision medicine for the betterment of therapies and the outcomes. What's about at home? When the patient goes home, you can still have the systems to help them out for compliance with the medication. Because the biggest problem we have when the patient goes home is the compliance of the care. And I think that can also be streamlined with all this AI in the medical practice. The list is exhausting. It's innumerable applications trials, predictions, high risk factors, precision medicine, access to healthcare, streamlining the healthcare, reducing the wastage, and also reducing the complications and the outcomes in the surgery as you can think about it. There are a huge number of companies which are interested currently in this era in the field, and the top couple are Google, IBM, Watson, and then the list goes on. The biggest role so far has been in medical imaging. Either it could be a CT scan, it could be ultrasound scan, it could be a plain X-ray abdomen. And why it has been biggest help is because you have multiple static and dynamic pictures in imaging, and these can be easily uploaded into the system for exactly getting the accuracy of the diagnosis and also predicting the complication based on the diagnosis. These are a couple of the United States organization which are really involved in the medical imaging and the AI. The market is huge, as I mentioned. Everybody is waking up and making a new company for AI, and there are more than 150 digital health companies in the process now. No, always, we are curious. Is this something new or was it there before? It's always been there. I think research is such a beautiful name. We are actually searching the re. And if you dig back into the history of AI, it goes back to almost about 70 to 80 years. In almost 1950s people thought about this some or other way, and but it was not until 2000 where slowly it got started to pick up, and the late 2010 I think it especially took off, but the COVID pandemic hit hard and it just busted, and huge inflation in the AI, because I think the COVID pandemic really was a setback for humankind, but also it brought a lot of new innovation, and AI is one of those. What's the market size for AI for those who wants to be entrepreneurs? United States expects that in next 10 years is going to be multi-billion dollar industry, which if you see in before pandemic, it was probably about 1%, but in 10 years down the line is going to go more than 300%. That's the projected $102 billion industry of AI in next 10 years. So this is for entrepreneurs who wants to be in the field of AI. I'm going to give some practical examples, and I've been involved in the AI for some of the projects and the clinical trials I've been doing in pediatric urology. Now, for those who are, still young aspiring surgeons, what is pediatric urology? Is we deal with the children with the kidney, ureter, and bladder problems. Most of the problems we have is the obstruction of the kidney, called as UPJ, obstruction of the urethra, called as push-urethral valve, reflux into the ureter, called as the vesico-ureteral reflux. And these are three common problems we encounter in pediatric urology. So what has been ongoing in pediatric urology is we have been working on imaging and exactly diagnosing some of the conditions and actually staging the condition, like how you stage the cancers. We stage the obstructed kidneys in different grades, and that can be used. We also can provide a risk assessment strategy based on the AI, and we can also better outcome their prediction and the spontaneous resolution and the natural history based on the models algorithm created with AI. If you look at the publications, as I mentioned before pandemic, it was probably 5, 10 publications. But if you look at it today, 2022, we have almost more than 50 to 60 publications in just pediatric urology. So there's a huge application in the diagnosis, in staging, and predicting the natural history series for the future. What is the common network used in AI for pediatric urology imaging is the CNN network, which is the convolutional neural networks. Now, these are all the computer algorithm terminologies, and it may be better for those who are aspiring to read a small books on AI. There are multiple small books on AI. It could be just a simple read, and I think we all should read about it because this is going to be a part of our future life and practice. So I'm going to take you through a project we have been doing with our colleagues in radiology and the radiophysics. As I mentioned, hydronephrosis. This is the kidney here. Hydronephrosis is the slow drainage of urine from the kidney and is essentially the urine collection within the pelvic calyceal system of the kidney. And we stage this on a scale of 1 to 4. 1 being just the pelvis dilatation, while 4 being all the calyces dilated with the thin renal cortex. So we have an inter-observer and intra-observer variation when we look at this grading of hydronephrosis. This SFU grading is mostly based in North America, but in rest of the world, the anterior-posterior diameter of the pelvis is used. But you can see that there are so many inter-observer and intra-observer variation. So we thought about how we can mitigate this problem. So after working with the radiologists and radiophysics, that we decided that we'll take about 100 patients. There were about 1,000 images, but initially we started with 100 images, and all the images were static, and we marked those. And our marking was an outline of the kidney, and then we marked the inside, the dilatation or the urine collection. And these images were then fed into the machine. The algorithm was developed, and we were finding out if the machine can differentiate the low grade versus the high grade. And it was able to with the AUC curve of 0.86, that is area under curve of 0.86. So that's almost close to 90%, which is incredible. This was our paper, which we presented it. Subsequently, we just published it this month and about our pilot study. What I'm going to do is little bit take you back that, some of you may do a research, some of you may do a clinical practice, but if you want to pitch in for a grant, how to write a grant. And one of my bright resident, Matt Sloan, and we worked together to make a video for a grant. So listen to this video.
It was an unnerving time. The loss of sleep, just wondering about what the different outcomes would be, made it tough to function normally.
Riley's baby Amelia suffered from a condition where mysterious blockages cause kidney swelling. similar to a clogged kitchen sink. This condition is called hydronephrosis, and it causes families a lot of stress while costing the US economy more than $90 million a year. The problem is that the way we diagnose and monitor babies right now is subjective. The way we look at ultrasounds now depends upon a human interpretation of things, such as how swollen the kidney looks. That means that treatment plans can depend upon the experience of potentially one single doctor, and that isn't good enough. And an incorrect interpretation could lead to kidney damage, kidney infection, or even kidney loss. So we need to be objective and we need to get it right. So let's use the same technology that Facebook uses to recognize our friends in our photos and help eliminate that human bias.
She had an ultrasound done and it was rated by the radiologist. And then it was also rated by Dr. Gundeti. And the two had conflicting grades. The guesswork caused me the most anxiety throughout the whole process.
There's a huge burden of not only the diagnosis, but of the parental anxiety. That huge burden needs to be counseled properly.
It's more difficult for the eye to pick out subtle changes in texture than changes in size or shape. And that's where a computer could help.
Those subtle changes have the potential to inform doctors whether or not a patient will need a kidney-saving surgery.
And that will help to counsel to the family, saying this is what the outcome is. The indirect burden that parents go through is priceless. You cannot put a healthcare dollars on it.
It was difficult to try and figure out what next week looks like, let alone next month or even tomorrow. There's a whole lot of unknowns in the air. Having a more uniform way to look at things might really give parents a lot of clarity and just like a little bit of stability.
So I think, it just, if you want to pitch in a concept for philanthropists or for donors, I think, it's the best way because not many people can understand when, we write it. I think the video has much more effect because it's concise. So these are our collaborators, and that's how we got the initial grant, and we worked on this, and we currently ongoing for the next phase of application for the grants and the next phase of the study. Now, if we can go back to next stage, that was for the diagnosis of obstructive kidney, but we can also predict based on the obstructive kidney who will need surgery and who doesn't need a surgery. And this also has a AUC curve of 0.9 zero 0.9, and this is the work demonstrated by our colleagues in North America. What happens after surgery? We cannot predict who will have a complication, who will have good outcomes and bad outcomes, but the AI can help us by feeding the data accurately so we can predict who is going to be at a risk of recurrence. The next problem, as we talked about, is a vesicoureteral reflux, where the urine goes back into kidney during micturition. And in this situation as well, we can have the grading of reflux, and that has multiple variabilities as well, inter-observer and intra-observer. But we can also develop algorithm to grade this hydronephrosis, grade this vesicoureteral reflux based on the dimension, and the machine can help us to exactly grade this vesicoureteral reflux. So that's the additional thing here. This is how it is calculated. I don't want to go in details, but just to show you the examples how to do the study and how this can be useful. Urinary tract infection is very common, as you all know, and we can predict the number of urinary tract infections happening after diagnosis based on the input of the data, and that's how the AI will come and help us. We can also look at the reflux resolution, that is a spontaneous natural history of the spontaneous resolution that can also be done with the AI's help. This is a hypospadias abnormality, which is the external deformity of the external genitalia in male, where the urethral opening is on a ventral aspect. And this is a phenotypic abnormality. And taking these pictures and feeding into the machine can tell you a little bit more. Not be that useful, but it could be useful for the beginners to think about how the anatomy looks. There's a posterior urethral valve, which is the obstruction of the urethra, and you can detect the obstruction severity symptom just based on the uroflowmetry. And you can also predict the kidney failure based on the input of data of the kidneys, the kidney function, and bladder function. And this is an immense value for counseling the families and the parents of their child in the future. So what's the future? I think future is always bright because I'm one of the optimists, and I think with the peer colleagues and with friends and colleagues and the next aspiring surgeons and the physicians, I think we can make better the human lives. And but the most important thing here is the ethics. It all depends on what we feed in the data. If you feed better, you're going to get better. If you feed the wrong data, you're going to get it out bad. So I think the ethical considerations are important, and I couldn't emphasize more. You have to be honest, critically, ethically considerative, and then I think the bias will be eliminated, the challenges will be much less, and the scope will be huge, and you will develop an expert system. Now, will this bring disparity? I think that's going to be a tough question to answer. But I think at this stage, we need to keep on moving and get to the system, develop it. And I'm sure we may reduce the disparity by everyone helping on the same note. What does the United States people think about this? Is this just a survey taken by the common people about, do you trust? There is a feeling about it. Some people will say, yes, I can trust AI. Some say no to AI. And that's natural. Human being is divided in any new technology. I think it onus is on us to make it better so that they can trust. This is, for example, skin cancer. Are you happy? Majority will say, yes, I can predict AI to help my skin diagnosis cancer, but minority say no. What are the other extreme applications? The applications are immense. Educational system, sporting industry, infrastructure, environment, crisis management, and economic empowerment. So, what are my conclusions in just a nutshell? That it's a very thought-provoking tool. I think it all depends on the users and also the feeding the system who is going to do this. Upfront is a huge cost, but over a long term, with the disruptive technology phenomena, it will come down. And I think the goal is to enrich the human lives. I think we may have 1 or 2 minutes. I'm just going to wrap up with the 3D printing. Now, you may have heard about what is 3D printing, what is 3D printing, and essentially the 3D printing is mapping of any abnormality or malformation, either phenotypically evident externally or is evident internally on radiology scans. And in this scenario here, for example, we're talking about the kidney tumor. So you can take a kidney tumor CT scan imaging and you can do a 3D printing, for example, in this situation here. And when you do the 3D printing, what it will tell you is exactly the location of the tumor. So when you go with a robotic surgical system, you're not spending too much time, you know where it was, and you often can practice before going in on augmented reality and virtual reality. So when you can go in, you can precisely excise the tumor. I think that's how the 3D printing helps. This example of one of our patient with a Wilms tumor here, and you can see a small tumor here on the right side kidney, and this was 3D mapped, even though it was not needed because it's external, but we mapped it out so that we could see this better. And when we went with robotic surgical system, we could know where the hilum is, where the vessels are, where the ureter is, and you can do a tumorectomy very well without damaging the surrounding organs and structures. Along with the 3D printing, the augmented reality and virtual reality helps us because the you can practice this before you can go into surgical room, and this is again incredible tool for learning and practicing. These are some of the pros and cons of 3D printing. I don't want to go in details. I think at this stage it's really helping for oncology patients. I think the field is expanding and it will be very useful. I want to spare 1 minute on the United Nations. Before the pandemic happened, their priority was how surgery can fight the global poverty. And they are actually making the surgical disease at the forefront. And as a part of this, we started our organization here in Solapur. Every year, we come in and do pediatric urology free surgeries, just to help the community, but also empower our local team of surgeons here. It's very important that the knowledge and skills should be exchanged. You should have the workshops, seminars, and this is what we do it at University of Chicago every year to share our knowledge and skills with our peers around the world. I've been very happy and fortunate to work with the colleagues all over the world, more than 30 countries, doing teaching seminars and workshops. And I think that I learned a lot as well during this process of my own thing. We developed a scholarship for those who are in urology and pediatric urology. This is an emerging opportunity. We developed a scholarship at University of Chicago, which is for a month, sponsored by University of Chicago, our section. So it's a time to hit refresh. Read this book. You can change the organization. You can change the system. Very provocative. And I think if we can need us because we need to monitor them. They don't have their own intelligence. So don't worry about it. Humans will never get replaced by the robots. So I'm grateful for all of you. This is immediate family and my extended family here in Solapur, all over the world, friends and families. I hope this was helpful. So if you want to get people to do something, make it easy, remove the obstacles. This is the good sentence by Richard Thaler, who is the University of Chicago Nobel Prize economist.